Welcome back to part 2 of our masterclass. Today, we're putting on our detective hats. Our core mission for this explainer is to completely decode those distinct, sometimes fuzzy clinical boundaries between sterile inflammation and a true pathogen-driven infection. As CDI specialists and medical coders, mastering this distinction isn't just helpful, it's literally the absolute foundation of accurate chart analysis. So, are you ready to crack the case? Let's get into it. We have to start with this crucial question to frame our entire investigation. Is it an actual infection, or is it just the body's internal alarm system going off? This is, without a doubt, the most critical dilemma we face when reviewing patient records. Why do you think we see such massive denial rates in claims for conditions like sepsis? Well, it almost always traces back to poor or ambiguous documentation of these two very different biological processes. If the chart doesn't clearly separate the body's natural response from an actual invasive threat, the coding just falls apart. Here is our roadmap for today. We'll be looking at the core of inflammation, the cardinal signs of inflammation, decoding inflammatory biomarkers, comparing inflammation versus infection, and finally, the CDI encoding impact. Section 1. The core of inflammation. Okay, let's dive into what's actually happening at the cellular level when the body faces harm. By definition, inflammation is the body's natural immune response. It's designed to protect against harm, injuries, irritation, or toxins. You can think of inflammation as the body's built-in fire alarm and sprinkler system all rolled into one. It's a localized, defensive reaction to a non-infectious insult. So, whether a patient has suffered trauma, maybe an autoimmune flare-up, an allergic reaction, or just exposure to some harmful stimulus, this biological alarm bell rings to kickstart the healing process. Now, when we're reviewing documentation, we really have to distinguish between an acute and a chronic state. Acute inflammation is a response to sudden body damage. It's rapid. It's the immediate swelling you get from a sprained ankle or the sudden redness from a chemical irritation. Chronic inflammation, on the other hand, well, that's slow and prolonged. That happens when the body fails to eliminate an acute inflammation. It lingers, right? And it causes long-term physiological stress. Knowing exactly which phase the patient is in helps us understand the severity and, of course, the expected clinical interventions. Section 2. The cardinal signs of inflammation. Let's see how that cellular alarm builds into physical, visible clues. As CDI specialists, you're essentially hunting for these 5 classic localized signs in the physical exam notes to validate an inflammatory response. We're talking redness, heat, pain, swelling, and loss of function. If a physician documents an injury or irritation, seeing these 5 clinical descriptors in the H&P basically confirms the body is actively mounting that defensive response. It's totally natural. But remember, the presence of these signs alone absolutely does not mean there's a pathogen present. Section 3. Decoding inflammatory biomarkers. Now consider this your ultimate daily cheat sheet for the key lab indicators used in chart analysis. When tissue damage happens, the body dumps specific markers right into the bloodstream. We're looking for elevated C-reactive protein, or CRP, and procalcitonin. We check for leukocytosis, which is that elevated white blood cell count. We're also keeping an eye out for an elevated erythrocyte sedimentation rate, or ESR, along with tumor necrosis factor, interleukins, and fibrinogen. When you see these labs spiking in a patient's chart, it is objective, hard proof of an inflammatory cascade. Beyond the standard inflammatory markers, we absolutely have to look closely at lactate. Lactic acid is just a byproduct of anaerobic glucose metabolism produced by tissues and mainly cleared out by the liver and kidneys. Normal levels are less than 2 millimoles per liter, but it is vital, and I mean vital, to differentiate the clinical thresholds here. Hyperlactatemia is a serum lactate of greater than 2, but pay close attention to this next part. Lactic acidosis is defined by serum lactate levels greater than 4. Noting this excessive lactic acid is super critical because it means there's either excessive production, like from tissue hypoxia, hypoperfusion, or mitochondrial dysfunction, or impaired clearance by the liver or kidneys. Section 4. Inflammation versus infection. And that brings us to the core dilemma of our investigation. How do we separate the body's alarm system from the actual intruder? If inflammation is the alarm, the infection is the burglar. An infection is strictly defined as an invasion and multiplication of microorganisms in the body. We are talking about external pathogens here, bacteria, viruses, fungi, or parasites taking hold in the host. The signs and symptoms, well, they're going to vary wildly depending on the severity, the type of pathogen, and exactly where they've invaded. This really brilliantly illustrates the clinical boundary we have to draw every single day. You've got a sterile host response, inflammation caused by injuries, autoimmune diseases, allergies, or toxins. And then you have a true pathogen-driven systemic infection caused strictly by microbial invaders. Think about it. A patient can have massive, severe inflammation from a chemical burn without any infection present whatsoever. On the flip side, a localized infection is definitely going to trigger inflammation. Recognizing whether the documented symptoms stem from the host's natural defensive response alone or from the multiplication of a foreign pathogen is the key to accurate clinical documentation. Section 5. The CDI and coding impact. All right, let's zoom out to the macro level and apply all this pathophysiology directly to coding compliance. While we act as medical detectives analyzing clinical criteria and lab values, we do have a strict boundary. A joint effort between the healthcare provider and the coder is absolutely essential to achieve complete and accurate documentation. Why? Because accurate code assignment cannot happen without consistent documentation. Plus, if a provider notes an infection but doesn't document the source or the specific organism, like let's say it's just a general sepsis note, we have to step in. We are required to query the provider for the source of the infection if it isn't documented. Look, this regulatory guideline right here from the ICD-10-CM official guidelines, it's our ultimate rulebook. It states explicitly, and I quote, "The assignment of a diagnosis code is based on the provider's diagnostic statement that the condition exists. The provider's statement that the patient has a particular condition is sufficient." End quote. This emphasizes that the provider's explicit diagnostic statement absolutely trumps any independent clinical deductions we might try to make from reading the chart. So here is the absolute most crucial point. Code assignment is not based on the clinical criteria used by the provider to establish the diagnosis. Even if we're looking at the chart and seeing all the biomarkers, the elevated CRP, the leukocytosis, the lactic acidosis, and we strongly suspect an infection over sterile inflammation, we simply cannot code it based on our own clinical definition. If the documentation is fuzzy about the presence of sepsis versus a localized inflammation or infection, we cannot just assume. We have to query the provider for clarification to ensure revenue integrity and strict coding compliance. So the ultimate question for you as a medical detective is this. If the lab values are screaming infection, but the provider's pen is completely silent, do you have the evidence you need to query and protect your hospital's revenue integrity? Think about that on your next chart review. Stay tuned for part 3, where we break down SARS criteria and non-infectious insults. Until then, keep learning and keep leveling up. This is Decode Healthcare with Harshal.